Of interest, so you know, I'm Gloria Hakarainen. I'm one of the fellows, and it's really exciting to see you guys here. About 5 years ago or so, I approached Pam and I asked her if we could have modules specifically for weight loss. And she said, why? She said, because everything that we teach in the module you can use for weight loss. I said, yeah, but I think it should be geared specifically for weight loss. And so, you know, how many of us have too many boards that we carry? So I have that same problem, too. I'm actually boarded in bariatric medicine and a director of a bariatric center at a hospital, as well as have a separate bariatric practice, as well as my main practice, which is OBGYN. It's a little busy. But it's important because patients who go to commercial weight loss centers are going to be put through this sort of 1, 2, 3-step mill. And that's not what we want patients to have for long-term success. In order for them to be really successful, care needs to be customized. We would never take a patient who had diabetes or high blood pressure or any of the above, polycystic ovarian syndrome, and do the same thing with them, put them through 1, 2, 3. We might do the evaluation and start in a similar way, but we would customize that regimen to the patient. And so I think for weight loss also, good success rides on the fact that we help the patient. And I explained to her there's many phases for weight loss. So tomorrow I'm going to show you one of my cases of a patient, hopefully walk you through what I do, and customize it for the patient. And the good question about the how many supplements can they take, you know, at a time, how many pills can you swallow, I totally agree on that. Remember, the liver and the kidney have to handle everything that you give it. And I personally think if you're swallowing more than 3 or 4 things at a time, I was a biochemist before at Harvard at the medical school, you're really not going to absorb it well. Your liver and your kidney have to process it out. It may become rather expensive. So I use other methods to give patients what they need after doing testing, right? I do intravenous vitamins, glutathione. I do sub-Q or IM. And those are options. And they bring patients into your office. And sometimes they bring the whole floor of deficiency up enough so they really get results right away. So you might want to look into offering that to your patients. It's much more convenient. I have some Palm Beachers, you know, they just kind of fly in and fly out there. They kind of do what they want to do sometimes. You know, you make plans for patients and they just kind of, yeah, that's okay. But, you know, the patients are so honest about that. They say, when I get that injection and I walk out the door, I feel so much better. Then I go have my, you know, my business meeting and my filet mignon. I'm like, oh, okay. You know, because you have to work with the patient. And it can get expensive as well. So if you have a patient where you have multiple things you want them to take, you might want to break it into weeks, because that's what I do with the patient. So they'll bring in all their stuff, and then we'll sit down and we'll do week 1, I want you to work on antioxidant. Week 2, I'm going to work on insulin sensitivity. Week 3, we're going to look on endocrine support. And maybe week 4, we're going to do kind of general things or arthritis or whatever is secondary. That way the patient can rotate through. The vitamins and minerals last longer. And they're not, you know, maximizing absorption. Oftentimes with these very pure pharmaceutical-grade things you're using, it's very difficult for the GI tract to absorb everything. And patients will complain, I can't tolerate that. And it happens even with the prenatal vitamins, which have minimal amounts of things that we give the pregnant women. They won't stay compliant on it either. If it's baby number 3, oh, no, I don't want to take that. And, you know, and you have to really sit there and explain why it's important. So you can do it. And yes, the High Fructose Corn Syrup Society exists. And if you get on their hit list, you will also be sent probably every couple of months, 3, 4 months, I get something from them, substantiating why they need to be around. Do you guys have any idea what percentage fructose to make high fructose corn syrup? Only 53% and 55% typically, and there's a 58%. So the rest of it is actually glucose, so you know. Okay. So have you ever had this story in your office where a patient says, you know, I decided I was going to get healthy. I actually, you know, started exercising. I eat less. I'm not moving. I hired a personal trainer. I'm in this class. You know, I exercise 2 hours a day. Nothing is budging. I'm not losing weight. And you believe them. You really sit down. You look at them in the face. You know they're being honest. They're talking to you. I'm eating like this. I gave up hamburger, whatever they said. And they're not moving. Well, maybe we should think about the word obesogen, okay? Last time when I gave this talk back in the summer of 2011, that was a pretty controversial term. I think it's more accepted now. Just in May of this year, they had a meeting at the National Academy for the Advancement of Science, and the director there actually used the term. And they're actually going to have a government-launched huge, this is a gigantic scientific research program, and starting with, I think, $20 million, and it's advancing on, to study obesogens. And the term was coined, I put it there for you, by Dr. Blumberg and his associate at UCI in California at Irvine, because they themselves, when they were first told that maybe, maybe it's really not all in the hands of the patient. Maybe it's not just a calorie in, calorie out issue. He poo-pooed the idea until he did some research onto it and found, wow, lo and behold, it's a lot more complicated than what we thought. And he changed his mind, and he brought it forth to the scientific community. And now it's a big hot buzzword. The word obesogen can be applied broadly. In his case, he was using chemicals that actually cause it. I'm going to show you some data later about 4 studies on different things, because there's just so many now. But I just want you to be aware of the term obesogen, because it can be used as an excuse, and we should not allow patients to have that as an excuse, but we should be aware that they do exist and what they are. And there's also, some things patients can do about them as they're trying to lose weight with you. And it really puts you on a different level, on a higher level than, say, the commercial weight loss center, right? So it's getting attention, the whole weight loss field, because of the babies. That's what started, I think, the whole push by the government. The Harvard School of Public Health came out in 2006 and then in 2008 with their landmark studies about obese 6-month-old babies. So these babies had fatty streaks in their coronary arteries. These babies had hyperplasia of adipose tissue. These babies are being treated well by their moms. They're being breastfed. They don't go to the gym, and exercise a couple times a week, and yet there's something wrong with these children. So it came to thought, well, what's going on? And then came this intense focus on studying these obesogens and what was going on. I don't know if you're familiar, 5-6 years ago, they actually did a study on the umbilical cord and all the toxins that are in umbilical cord. And all the ones that they sampled, pretty much they found every single one. And many of them, they found them in levels that are really too high, levels above what the national government standards are set at. So they wanted to know, how did these babies get this? And did it make any difference in these children? And remember now, when you talk about the term obesogen in this light, it's a very serious thing, because you are making a genetic change. You're determining different cell lines of differentiation in utero, and the child has permanent changes that are going on metabolically. You're changing the whole set point, and this is not something that's reversible. So in my field of obstetrics, of course, I get very concerned with that. So if I have a patient walk in the door and say she's thirsty and she's got that soda pop can, I'm a little bit different from my colleagues. I'm going to take a little bit extra time to say, hey, we can make you something that sparkles, that tastes good, that's yummy. There are these areas. You can go to the store now and buy a pump. You can carbonate the water. Just be careful of the phosphoric acid in it. You can put in a splash of juice and make your own spritz. But it's definitely better for you. And what will it do to your child? An interesting comment was made by Walter Willett. I don't know if you're familiar with him. He's in Harvard at the School of Public Health. And when I went back to the Harvard Obesity Summit back in 2000, he had made a comment about, do you guys remember the trans fat issue? About taking trans fat out of the diet? And he said there's no role for trans fat in the American diet, period, whatsoever. Now, the reason why there is trans fat at all in the American diet is because if we look at the way the fat molecule is, under high pressure and high heat, we can force a hydrogen atom to go from the cis configuration, we're both on the same side of the molecule, to the trans configuration. And based on that, that fat becomes extremely stable. And so, these companies, these food manufacturers that make their products, they make their food products a long time before you eat them. So they actually truck them and they store them in a warehouse, and 3 months before they go bad, they stick them on the shelf. So that was obviously for them, it's a cost-effective thing. The food doesn't go bad. But he was pointing out that as little as half a gram per serving adds up, and for kids, up to 3 grams a day was going to be a problem. He actually used cancer as his #1 issue to get the food industry to listen to him and government to step in and regulate trans fat. So, I was thinking, wow, that's pretty exciting. So we turned over there in like 2004, so like 3-4 years later, and he's saying, yes, there's now a government-mandated policy. It's coming out soon. They're going to have to push the manufacturers to list whether or not there's trans fat. So that all seemed good, right? And in 2007, probably by then, you saw that there's, all these labels on foods, right? No hydrogenated oils, no trans fat, but, there's a loophole. And the loophole is a scary loophole, and that's why I want to bring it forth, because it's going to happen to this too. The loophole was less than half a gram per serving equals 0. So they can actually label no trans fat on the beginning of the package, and if you flip the package over and you actually go to the ingredient list and you look to see what's in there, if there's more than half a gram per serving, they have to say it. So what do they put it at? 0.4999, yeah, And he was mentioning back at the 2007 summit how disgusted he was with the whole thing, that now you have a child who could, be at school, and let's say you don't give the child anything in the school lunch that has trans fat, but he borrows his friend's, cookies, packaged cookies, goes at snack time and they give him crackers, okay? These all have like about half a gram serving, right? And then go to play and they eat something else and come to dinner. By that time, they've had 3 grams. And what can you do with that trans fat? That was the other thing that was so evocative by his data was you can't clear it. It is in that cell membrane forever. Forever. It's a very stable molecule. It's in that phospholipid bilayer that we know of the cell membrane. And the phospholipid bilayer has to be mobile. It's an undulating membrane. And in it come big receptors, big complexes. The GTP receptor, et cetera, is so important. And if you can't clear this out, when things come to dock on, any antigen or molecule comes to dock on that cell membrane, it can't, because that part of the cell membrane is dead to communication, leading to cell apoptosis, leading to increase in tumor necrosis factor, and et cetera, et cetera. So it's just one comment I want to bring forth to you, because if we don't step in as a community and specifically ask or just decide we're not going to buy these products, it's just going to keep happening, And as far as the soda pop thing goes, they actually have paid the school, these companies, to move the soda pop machine that much closer to the door. So when the kids pop out in the hallway, it used to be that there was maybe one, kind of snack machine, and you'd have to go to the other end of the school to go get it, right? No, now they actually pay them more money if they will move the pop machine closer to the door. And so there have been big movements in bariatric fields to try to discourage that and get that out. And it's happening. I mean, we're not the only ones that are involved here. For example, in LA, where they have one of the largest public school districts in the country, they made a big move to take all the stuff out of the vending machines. And they got threatened by those pop companies and by these companies that make the crackers and such not. And they put in yogurt and fresh fruit and other things. And they put in water. Fortunately, it's in plastic, but we'll go over that in just a second. But they at least tried to do these things. And what did they see happen? 600,000 vending machines a day that these kids are going to, making purchases. It's a lot of money for those companies. Yeah, their IQ scores went up on the California assessment tests. Some of the kids have been labeled ADD at a special school. We're no longer ADD according to criteria after 3 years. So we can make a difference. The state of Maine, every single public school, they've taken all that out of the vending machines. We just have to be more proactive, but we can. Okay, so there's something going on. The worldwide toxic load is going up, and I'm going to show you some data, but if you really want to see the data where you can convince yourself of what's going on, it's actually really eye-opening. Dr. Benoit Tano, he's another fellow here. He's an epidemiologist, and we basically, in the next module of 14, go on and you'll look at all the persistent organic pollutants, and you're going to see them. He lists them like A through Z. And he actually goes to government, and he goes to testify before Congress on the levels of these POPs. And what he'll do there is very interesting. He'll show you the map, the CDC map, the obesity map, and he'll say, what do you guys think about this map? What are the 3 most obese states in this map? And so, we all talk about the Deep South and where it is. And he goes, well, what do you think they have in common? He goes, if you look at the pattern of obesity, it's actually a contiguous pattern. It looks like an infection, like a spread of infectious disease. He said, what do those 3 top states have in common? They have